Доктора Султан Рахман. Он расскажет о гипертерапии на фоне химиотерапии, или наоборот, химиотерапии на фоне гипертермии, больных саркомом мягких тканей.
Yes, Chairman, dear colleagues, I am very happy to present the new data of our randomized study, which was published before 2 days. The take-home message of Fabron that we have now effective hyperthermia system to heat deep-seated big tumor in the abdomen or pelvic area as soon as tumor in the superficial area. That is the message of Fabron, and the message of Mark Horowitz that we have a long-term effect of the hyperthermia, an immune effect which had a long duration and not a time of few months or few years. And the question was from the auditorium for some minutes, how we do hyperthermia clinically, and do we have a long-term effect of the hyperthermia? And that's what I want to see in this lecture, which was published for 2 days. I will go forward for this slide because now we know what is hyperthermia. Yeah? The most important thing which was found in our clinical result that we have seen 90-90. There is a relationship between temperature, what we measure in the tumor, and the clinical output. So there is a relationship between clinical response, radiological response, and measured temperature. In the 30 years of our experience, we have do a series of clinical study to answer the question, is the hyperthermia clinically effective in high risks of tissue sarcoma? And if this hyperthermia effective, is it a long-term effect or only a short-time effect? To this question, we have started with a phase 1 study by patient in the second line, and we have seen an effect in the second line therapy and published in GCO, and it was 91 where we started with chemo-naive patient giving chemotherapy and hyperthermia, and we have seen an effect which we have published in 2001. And then we started especially a retroperitoneal visceral study for a huge tumor of a diameter of at least 8 centimeters to see if there is an effect also in this deep-seated hyperthermia, deep-seated tumor. And we have published in JCO2 2002, and after that we started a randomized phase 3 study prospectively randomizing chemotherapy versus hyperthermia versus chemotherapy alone on 341 patient multi-center study in 6 countries. The result of the phase 2 studies, we have seen there is a relationship between temperature and radiological response. The next question, is radiological response bringing overall survival? Yes. Response radiological response is predictive for overall survival, which we have published in GCO 2002. After that, we started the randomized phase 3 study, and we published the result of this study 2010 in Lancet Oncology with a median follow-up time of 3 years for all patients. And now for 2 days, we have updated this result and published them for 2 days in JAMA Oncology. Here we see the short time of a median follow-up of 3 years. Here a median follow-up of 11 years. What we have done, we have 341 patients randomized in the study, 196 in receiving neoadjuvant chemotherapy plus hyperthermia, and 172 in neoadjuvant chemotherapy alone. 12 patients didn't receive the therapy, staying 329 patients in the study with a median follow-up of 132 months. This is the design of the study. We randomized 4 cycles of neoadjuvant chemotherapy, day 1 to day 4, receiving ifosfamide, adriamycin, and etoposide. In day 1 and day 3, we give the patient hyperthermia. The other group received only neoadjuvant chemotherapy. After that, we test the response on the therapy, and we started the definitive resection. And here, most important to see, 148 versus 151. Both groups, the same number of patients, received the definitive surgery. And the next step, the radiotherapy. Both number of patients received the same radiotherapy. After that, we started a post-operative chemotherapy consisting of 4 cycles, day 1 to 4, of chemotherapy, and day 1 and day 3 hyperthermia. And the other group received the chemotherapy alone. Main point of the study, local progression-free survival only. So we wanted to have the disease-free survival as main point of the study. The ERTC refused it because said you give both patients a systemic therapy, both group of patients receiving the same chemotherapy. Only the hyperthermia group receive hyperthermia. And hyperthermia is a local therapy. So your main point must be the local progression-free survival. The second endpoint were tumor response, disease-free survival, and overall survival. And this is here the answer of the JAMA Oncology. We see here both group, hyperthermia and chemo versus chemo, is the same number of patients. We have the same order, 51 years to 52. The male number is the same number in both groups. The performance status of patient is the same in both groups. And the most important in this study, the most number of the patients have a retroperitoneal or abdominal tumor. And here you see that the presentation of the tumor, 75 have primary and 68 have prior surgery. So this is the number of patients who have received the surgery before starting the randomization. And both groups are the same in both arms. Here we see the tumor diameter. We have huge tumor here, more than 12 centimeter. And we have the median of 11 centimeter in both groups. G2 and G3 are the same in both groups, and the pathology, the most tumor are L sarcoma, like liposarcoma and limbosarcoma. So we have no G1. This is only high risk soft tissue sarcoma. And 80% of this pathology was reviewed by the ERTC. The first result of the study was after 4 cycles of receiving the chemotherapy and hyperthermia, test the radiological response. And we see here the most important response. The partial response in the hyperthermia arm is about 28%, and in the chemotherapy about 13%. In the same time, we see the progressive disease in the hyperthermia arm only 7%, but 21% in the chemotherapy alone. So this is main difference in response and in progressive disease. And the p-value of this result is 0.02. 96% of the radiological response was reviewed by the ERTC. Next point, that we, as I have mentioned, we have given the same patient surgery in both groups. But what we see here, that we have in hyperthermia arm 51 patients with R0, but only 41 patients in chemotherapy alone. That means shrinkage of the tumor volume through the preoperative chemotherapy treatment produce R0 resection in the hyperthermia arm. And we have seen response produced overall survival. And the radiotherapy, the same number of patients, they have received the radiotherapy. So there is no any difference in the therapy regimen in both arms. And this is the result. This is the main point of the study. Local progression-free survival, and we see here a very defined benefit for the hyperthermia in a local progression-free survival. From beginning of the study, we've seen the benefit of the local disease-free survival in the hyperthermia arm due to the chemotherapy alone. And this is not the main point of the study, but although we have here a very clear P0.1, a benefit in the disease-free survival. Despite the fact that we give only a local treatment, the hyperthermia, but despite this fact, we have a disease-free survival. And this is what is the newest result. The question was, do we have a long-term effect of the hyperthermia? Yes, we have a long-term effect of about more than 15 years of overall survival in the intent to treat analysis, that is not in the efficacy analysis. So each patient, despite the fact if he received 1 cycle or 8 cycles, he have the benefit of hyperthermia in overall survival. And this is the first time that we've seen a long time with a follow-up of 11 years, a benefit for a neoadjuvant chemotherapy combined with hyperthermia in a high-risk tumor. Forget the big numbers, only 3 numbers are important. Local progression-free survival, 5.6 versus 4 years in the local progression benefit, so 200% about. The same in the disease-free survival, 2.8 versus 1.5, and in the overall survival, 15 years versus 6 years. That is long-term survival of a high-risk tumor. The next question may be, which group of the patient have a benefit of the treatment of the hyperthermia? Each group of the patient group, young patient, they have a benefit in the overall survival. Site of the tumor, extremity, non-extremity, especially by extremity, the most surgeon, they said, we don't need hyperthermia. We make the operation and that's enough. We see here the input of hyperthermia also in the extremity. It is, we see in primary or in prior surgery. So if you give the surgery before starting the treatment or after 4th cycle, you see the benefit. Here, in the record situation, we say no benefit, but that's due to the small number. That's a statistical problem. And here we see the surgeon of our department. They say maybe this is a result of the good surgery. We have seen, we have all R0 have a benefit. R1 have the same benefit. And R2 had no benefit, but we have seen in the analysis, R2 are more in the chemotherapy arm because they have a high number of progressive disease during the treatment, but low number only with the progressive disease during the treatment in the hyperthermia arm. Radiotherapy, it is not the effect of radiotherapy. If you give the patient the radiotherapy or if you not give him the radiotherapy, both groups, they have a benefit of the hyperthermia. And it is not a question of the size of the tumor. Small tumor and big tumors have a benefit of the hyperthermia. And in our study, it was designed as a high-risk tumor. That it means tumor diameters at least 5 centimeters. And here's the most important thing. We see that grade 2, which is normally not sensitive for chemotherapy, has more benefit than grade 3, which is sensitive for chemotherapy. And we have published that hyperthermia enhance the sensitivity of soft tissue grade 2 tumor for chemotherapy. So you make tumor more sensitive for chemotherapy if you give them a thermosensitive chemotherapy combined with effective hyperthermia. And we see here the L-sarcoma, so that there is the kind of sarcoma, so the sub-pathology, there is no role. All patient group have a benefit of the hyperthermia. And here, the induction. This is not important. We have tested in the phase study result that only after 3 years was only the patient who have received at least 50% of the treatment have a benefit in the overall survival. Now all patients have a benefit of the patient. So all patients have a benefit of the hyperthermia after 11 years. That is a long-term effect. So the result for patients with locally advanced high risk of tissue sarcoma of adults, the use of pre- and post-operative chemotherapy combined with regional hyperthermia result in significantly increased response rate, local progression-free, disease-free survival, and now overall survival. And these results are translated in the overall survival benefit, and this is finding to provide strong support to use regional hyperthermia setting in new standard treatment. Therefore, we started the new studies, and the result of this study was taking the hyperthermia and the NCCN guideline for retroperitoneal and abdominal tumor, and in the European clinical practice guideline. So the hyperthermia for high-risk tumor is not more an experimental equipment. It is in our department with more than 1,000 sarcoma patients in the year, a standard treatment modality for patients with high-risk soft tissue sarcoma. Thank you.
Спасибо большое. Если позволите, я задам вопрос. Конечно, ретроперитониальные и абдоминальные саркомы мягких тканей, они отличаются по течению, по результатам лечения с опухолевой в конечности.
Он не слышит.
Слышит? Слышит, да.
Can you repeat it?
Да. Вопрос такой, что, конечно, если говорить, два вопроса касательно ретроперитониальных опухолей и абдоминальных. Значит, здесь, конечно, преимущество химиотерапии по сравнению с лучевой терапией. У меня вопрос конкретный такой. Благодаря такой качественной гипертhermии, как вы смогли перегреть, потому что гипертherмия это есть перегревание, не нагревание, а перегревание тканей. Как вы смогли перегреть опухоли, потому что все опухоли ретроперитониальные, они рядом находятся, ну, например, с почками. Они все, практически все опухоли окутывают почки. Были ли у вас сложности с прогреванием, перегреванием опухолей и какие были ответы со стороны ближайших органов, которые критически могли ответить на температуру?
Yes, I have answered the question. I have understand the question.
Microphone.
I don't present the side effect of the hyperthermia because we have presented it in our Lancet Oncology. We have not seen any side effect of the hyperthermia of toxicity of grade 3 or 4. Only toxicity grade 1 or 2, the maximum systemic temperature increasing due to the big tumors was 1 grade in the patient, and what we have seen as a side effect of the hyperthermia is not in the kidney. We have seen in the leukopenia rate is in the hyperthermia treatment group significantly higher than in the chemotherapy group. And we think that's due to the fact that more than 70% of our patients have a tumor in the visceral and retroperitoneal, and we heat the pelvis bone with the most blood producing. And due to this fact, we have a significantly higher leukopenia rate in this group. But despite the fact that the most patients have a diameter of 12 centimeter, we, after shutting up the system, you don't see any effect of the hyperthermia regarding toxicity. So as Van Roon told, we have a system of 24 dipole antenna. Increasing the number of antenna, as Van Roon mentioned, mean that increasing the homogeneous temperature distribution on the tumor without damaging the fat layer of the patient, especially the European patient with a fat diameter of over 2.5 centimeters.
Спасибо. Да.
Yes, I think the real answer to your question lies in the specific tumor entity. The specific tumor entity of soft tissue sarcoma is a solid tumor, which means it is heavily underperfused as compared to all the surrounding tissue. And this means it absorbs preferentially any kind of heat which you apply to the body. And this is the answer why all the other surrounding organs can absorb less. And also this technology focuses the energy on the tumor without leaving too much energy to the surrounding and more superficial areas.
Еще вопрос?
Скажите, пожалуйста, а общая температура тела повышается? В концерте гипертермии, сеанс гипертермии, до скольки повышается общая температура? Спасибо.
In our department, a deep-seated tumor, we have average 1 grade increasing of systemic temperature after the end of the treatment, not more. So we started with 36.7 and finished with 37.7. That is so cooling, as was mentioned by Van Roon. Cooling the patient during the treatment reduce the systemic stress of the hyperthermia.
Спасибо. Если позволите, у меня один вопрос, короткий, но длинным объяснением. Значит, у нас большой опыт лечения больных сарком мягких тканей. И вначале мы лечили пациентов с локальной гипертрофией, терморадиотерапией проводили. Были хорошие результаты непосредственные, намного лучше, чем после одной лучевой терапии. И было нормально. Но все равно больные погибали от отдаленных метастазов. Поэтому подключилась химиотерапия, когда мы проводили еще химиотерапию при саркоме мягких тканей, не использовалась широко. Но в последнее время хирурги стали обращаться только к химиотерапии. Они сочли, что химиотерапия влияет непосредственно на первичный очаг, что я не совсем с этим согласен, и поэтому к нам пациенты приходят после 5-го, 6-го, 10-го рецидива, приходят, и они упорно не хотят этих пациентов лечить. Какие у вас пациенты были, первичные были, проводили ли вы предоперационную терморадиотерапию, или сразу начинали с химиотерапии, после операционной, в зависимости от степени злокачества, проводили лучевую терапию? Спасибо.
I understand the question. Each patient with high-grade soft tissue sarcoma, high-grade mean grade 2 or grade 3, not grade 1, and diameter at least 5 centimeters, and deep and extra compartmental. So if the patient have G2 or G3, we started, despite the fact if he was pre-operated or not, with chemotherapy and only thermosensitive chemotherapy. That means ifosfamide and doxorubicin combined with hyperthermia. No chemotherapy are only by G1, not by G2 and not by G3. We treated patient with metastatic if there is a metastatic in the set. So it is included in the applicator of the hyperthermia. We don't treat patient with distant metastasis in the brain or the out of the set of the hyperthermia. We treated patient with soft tissue lesion, which are included in the treatment of interest. And that is the philosophy of our sarcoma center.
Спасибо. Евгений Витальевич.
Thank you. It's fantastic, no doubt. But any question arises, and the first few words about the dose of radiotherapy.
The dose of radiotherapy.
Dose of radiotherapy. And the second about local complication after surgery.
The schedule of radiotherapy.
Yeah.
Yes. All patients receiving a defined radiotherapy dose depending on the surgery. So patient with ER2 resection, they receive about 64 Gray. Patient with ER0 resection, they receive about 59 Gray. And this is so the question of the resection, and this is defined in the tumor conference and in the study protocol. In the study protocol, this is described the dose in relationship to the surgery results, and the side effect of the radiotherapy was in both groups the same, because the patient received the radiotherapy without hyperthermia. So the hyperthermia, the radiotherapy was after the surgery without hyperthermia, and then we started with a post-operative hyperthermia and chemotherapy regime.
Okay, fine. And complication after surgery.
The complication of the surgery, we have published in the Annals of Surgery, we have about 1% of amputation regarding radiotherapy in the extremity situation. So patients with extremity tumors, they have received radiotherapy, and in the extremity, after the radiotherapy, we were in about 5 cases. We must make the amputation due to the side effect on the radiography, but only in the extremity situation.
Okay.
Thank you.
Спасибо. И очень короткий вопрос предыдущего докладчика. Как часто в неделю вы проводили гипертонию?
Can you repeat it, please?
Как часто в неделю, по неделям, вы проводили локальную гипертонию? Сколько раз в неделю?
We give the hyperthermia in 4 cycles. In each cycle, in 2 days, day 1 and day 3. So 4 cycles, it means 8 hyperthermia pre-operative and 8 hyperthermia post-operative. And that means 16 hyperthermia each patient received in this study. And now it's the standard in our department, 16 hyperthermia in day 1 or day 3, day 1 and 3, or day 2 or day 4. So we give the patient 1 day off between both hyperthermia, 2 days in 1 cycle, and the cycle is 4 days.
Все, спасибо большое. Есть еще вопросы? Нет, спасибо большое за прекрасный доклад. Приступаем к следующему докладу.